Dr. Cabullo, are you there?
Hello, Dr. Bennett.
Hello, good morning. Hey, Francisco, how you doing?
Hi, I am awake from the New Year, and I'm happy to be here. I think
good.
that I gonna moderate this lecture. So can you make me panelist, please?
Do you want to host?
Yes.
Oh, I'm sorry. Let me turn off the YouTube here. I got to get that mute. That is a delay.
I'm sorry.
Yeah, now we're on here. Yeah, I don't have your picture there. You don't have to come on now. Okay, Francisco, let me grant you, try to let people promote people, okay?
Yes.
Okay, I just promoted you. Do you know what I mean? Okay, let me promote panelists. Okay, now that you're in, I can give you privileges. Where are you at? Oh, there you are. Okay. Okay, I gotta do a few things, so just promote, okay? Okay, Francisco? Hello?
Hello, Doctor. I'm here. I was connecting my microphone
Okay.
because I think that in the last time we had some trouble with my microphone. But
Oh, okay.
now I'm here.
How about your camera? Is your camera okay? Okay, there you go. Are you gonna host?
I'm sorry?
Are you going to host?
Yes, I'm going to host.
Okay, your name's Paco. He called you Paco. That's confused me.
Yes, I'm sorry because my Google account, I had to
Yeah,
go
it's like a
to
nickname, yeah, I know, we have them too. Okay, I'll be back, all right? And do you know how to promote people in the panel?
Yes, I'm going to promote people to
Yeah,
panelists.
watch people when they come in, try to promote them, okay?
Yes.
Okay, I'll be back.
The lecture is beginning in 30 minutes, right?
Yeah, in 25 minutes, right?
Yes. Okay. By the way, Doctor, Happy New Year.
porque
Oh. Okay. Good morning, everybody. Not a big crowd today, but I didn't expect it. So how are things in Mexico? Oop. Bad camera. Okay, you know, I'm not sure we're gonna do the lounge. We'll see who comes, okay, Francisco?
Yes, I will be in the lounge.
Yeah, there was one guy, he was here, Dr. Cabulo. I want you to meet him. He's from the Congo. He must have dropped out.
I'm sorry, can you repeat the name?
So his name, oh, there's Sarath is here.
Yes, I think that the speaker is in the.
You just let him in, right?
list. I'm sorry?
Did you just admit Sarath?
I think that my audífono it's not working well, because I'm not listening in the best way. But I think that yes, the speaker is in the.
There's Sarath right here. Good morning, Sarath.
Hi, good morning, John. And wish you a very happy new year.
Good morning,
Okay.
Dr. Surat.
This is Francisco. He's going to moderate today. He's going to
All right.
host.
That's
Gotta
great.
teach the kids.
All right. John, give me a few seconds, right? I'll be back. Huh?
Geez, I'm having trouble with my audio. I don't know. Does this audio sound good to you, Francisco? Go ahead, Sarath. Talk a little bit.
Yeah. Can you hear me, John?
Does this sound okay?
Okay, yes.
I can hear you. Can you hear me?
Yeah, now it's better.
Yes.
It's better. Yeah, it's
Right,
better.
okay.
I don't know what was wrong. Maybe it was my computer.
Can you
So-
give me a few minutes? I'll be back. Right?
Yeah, okay. Yeah, we have 9 minutes, so.
Okay.
Doctor, I'm sorry, I am listening right because I don't know if I had trouble with my microphone, but do I listening in the right way? Me?
It sounds okay.
Yeah, thank you.
Yeah, well, I'll be here. If it screws up, I'll just tell you and I'll just take over. Okay?
Okay.
Yeah, if there's any problem, I'm here.
Thank you.
Good morning, Zanab and Natambi. Rose.
Good morning, sir. Happy New Year.
Yeah, welcome.
Thank you, sir.
Yeah, well, I guess we'll have the lounge after because there's people like Zanab you should meet. I don't know if you've met her. I think you're in Africa, right, Zanab? Zanab?
Yes, sir. I am.
You're in
Yes, sir. I'm from
Guinea.
Africa.
Yeah, she'll show you where the country is. There's another African neurosurgeon student, Natambi. How you doing, Natambi? Can you hear me?
Hi, John. I can hear you. How are
Oh,
you
great.
doing? Happy New Year.
You're a student, right?
I am a pre-intern now. I finished med school.
Oh, okay, you finished. Oh, okay. You're an intern. Okay. Okay, welcome. We'll meet in the lounge after, okay, and chat. And you meet other people, okay?
Okay, thanks.
Okay, and Zanab, I hope you come. There's Mauricio.
Yes, sir. I always find it difficult with the launch. I try to copy and paste, But I don't know, for some reason, I just missed it. I keep missing it.
I have, my hearing's not too good. I have no idea. What did she say, Francisco?
I have trouble with my audífono, so I don't listening good.
Oh, you don't hear anything either?
Yeah,
Uh,
and
Yes, I was just trying to say I will try to log in today in the launch, but usually what happened is I try to copy and paste, but I keep missing it. So for some reason, it haven't been working for me.
Yeah, well, it's, as you know, it starts after this Zoom, and it's a separate link. It's not the same link. And I'll give you the link before we
Okay, sir.
stop. Before we stop, I'm going to explain it again and then give you the link. Most people have no
Okay,
problem
sir.
if I explain it correctly.
Okay, sir. Actually, I understood. It's from the chat. You copy and paste, and then you get the new one. But for some reason, it haven't been working for me. But I will try again today.
Okay.
Thank you, sir.
Okay, welcome.
Mhm.
5 minutes. I wonder why they were shooting fireworks off last night. It's New Year's. I didn't even realize it.
yes, here in Mexico we have a lot of party in the New Year, and I think that my neighbors is still in the party now because I am listening music from the neighbor.
Yeah.
So
It's a
I'm
big-
sorry if the music listening in the chat in the Zoom, but because it's very loud, their music.
Is it a big holiday in Mexico? New
I'm
Year's
sorry?
Day? New Year's Day, big holiday?
Yes, it's very celebrated this day. I think that in Mexico it's sometimes more celebrated the New Year than Christmas in some regions.
Yeah, how is it in Sri Lanka? Is New Year's a big holiday or no?
Not really, John. We
Christmas,
celebrate
Christmas is big, right?
Yeah.
Christmas.
Yeah. It's a public holiday on 25th of December, and the majority of Sri Lankan population is Buddhist Sinhalese, and it's
English?
yeah, it's minority. It's being celebrated by the Christians, and but it's actually it's a festive season, so doesn't matter where we are Buddhist or Christian, so they enjoy, they celebrate. But the main the festival in Sri Lanka is what you call the Sinhala and Tamil New Year, which is in April.
When is that?
That is in April, mid-April.
April?
April, yeah.
Oh, okay. Well, here in America, it's just a holiday to get drunk. Most people get drunk last night. New Year's Eve is known for that. That's basically what it is. It's not a religious holiday, and it's not like Christmas, not like Christmas. But anyways, yeah, after this webcast, Sarath, I'd like, if you can, come to we have an after Zoom, okay?
Yeah.
I'm going to give you another link at the end where you come into that Zoom, and that Zoom is informal. It's not recorded, it's not televised, it's not broadcast. It's just for you to meet the students and the residents that came to your meeting.
That's great. Yeah, great idea.
Yeah, it adds. I like it. I think Francisco likes it. It gives a little personal touch and a little more interactivity. so that not, because I know when you go to conferences, the big benefit is meeting people. Meeting
Exactly.
people. I mean, and we're not doing that. We're not, you know, people coming to Zooms and leaving Zoom and not meeting anybody. So, although you do get to know the person better by physically maybe interacting a little bit. We'll see. It's going well so far. Okay, we
I
have
used
1
to say
minute.
that the Zoom launch is like the meet and greet of the lecture.
Yeah, until Zoom starts doing something. And I can't believe that they don't have what's called breakout rooms. Have you guys heard of that?
Yeah.
They don't have that in webinars. They have it in meetings, but I can't broadcast meetings to the internet, so I can't do meetings. I do webinars. But they've got to be doing it soon, I think. Anyways, are you ready to start? Okay, Francisco, I'll just count down and you say hi, you start, okay?
Okay. I'm ready.
Okay. 10, 9, 8, 7, 6, 5, 4, 3, 2, 1.
Hello, everyone. I am Francisco Garcia. I am part of the student team of Neurosurgical TV, and this, our first lecture of 2022, we present the Dr. Surat Munashing with a lecture about manage of complex neurosurgical case with minimal resources. Doctor, good morning. The screen and the microphone is yours. Please start.
Thank you, Francisco. And good morning to you and wherever you are. Good morning, good afternoon, good evening. And it's almost 7 o'clock in my country, and wish you a very happy and a prosperous New Year 2022 for everyone, and John as well. So, so it's actually it's been a privilege for me to start actually the first webinar for the Neurosurgical TV 2022. So I'm going to start my the presentation, and I'm going to share my screen. Can you see my screen?
Yes, it's perfect.
Good. All right, great. Okay. So the presentation today is going to be on management of complex neurosurgical cases with minimal resources. And actually, I started presenting my first webinar. I can remember last year, 4th of January, and it was the topic was a neurosurgical perspective from a periphery in a third world country. So actually, I'm really sorry, because I have been most of the times during my presentations, I have been talking about the difficulties. And I know that people talk about all these hi-fi stuff, advanced stuff, actually, which is the way forward without any doubt. But for people like us who are working in peripheries, in especially third world countries with minimal resources, people know who have experienced that we have been going through so much struggle and obstacles every day routinely. So through the Neurosurgical TV, so you saw so many advanced techniques and knowledge, but people very seldom talk about what is behind the scene, mainly the difficulties and also sometimes the failures. And for example, the difficulty which is encountered in producing the outcome of a patient's case. So we rarely talk about these things. So actually, I thought of talking about this a little bit today. So how you can tackle complicated or complex neurosurgical cases with minimal resources in a remote area. So as a neurosurgeon at a periphery in a third world country, so how much you are skilled and how much you are capable, most of the times you will be frustrated. That is natural. And we as a poor country, we have very limited resources. And on top of that, people, they don't have much faith on neurosurgeons or the neurosurgical field. Sometimes they have the fear of death and disability following surgery. And some people think succumbing to disease is sometimes better than suffering from a post-op complications. And for example, say patients coming with back pain, more than 80% of people believe that they get paralyzed after lumbar surgery. So that is the mentality they have, especially in a country like my country. So I just presented this cartoon to you. As a neurosurgeon from this part of the world, say, for example, you get a case and you are given the opportunity to operate. And it's like getting through a river by various methods. And you can see, actually, my journey for the last 3 years has been like the first 3 pictures, right? So you got very little support and you are all alone. And I'm sure most of you may be under the other categories like 7, 8, 9. So you don't have the luxury to cruise through to your destination from the start as you wish. And so many obstacles. So we have to fight again, not only against the pathology of disease as most of the people do in affluent countries. So we had to fight against the infrastructure, mainly the pathology of the disease, number one, the infrastructure, the resources, and sometimes in this part of the world, patients misbelieve because these patients have a lot of misunderstandings and also sometimes benefit of the colleagues. So in a country, especially the third world country, what is the problem? Actually, it's the problem with the system. So we need a system change, but why can't we create that system change? It's because of this. So you need to have all these components. You have to have a vision, you have to have skills, incentives, resources, an action plan to make a change. Most of the time, the vision has to come from the leaders, the rulers, the administrators. If you don't have a vision, you end up in confusion. Skills, most of the times we have the skills. If you don't have the skill, you end up in anxiety. But we have the skills, we don't have the incentives. So much resistance. That is one reason that there is resistance most of the times. And then come the resources, which is the most important and which is the most relevant part for us. You end up in frustration and already frustrated. And if you don't have the action plan, you end up in false start. So we have the skills, we have action plans, we are lack of the others, right? Yes, no one is more hated than he who speaks the truth, right? So I've been already been hated for speaking the truth, right? So these are the obstacles that we encounter every day from admission to discharge. For example, this is for me. If you take me as an example, for me, we don't have much beds, so there is no space for admission. And investigation-wise, sometimes not available, poor quality. And on top of that, you have to convince the patient that it needs the surgery as well. So unlike in other neurosurgeons, you have to think about all these things. So you have to think where you're going to admit the patient, and you have to convince the patient that it needs surgery. And sometimes preoperatively, you don't have theater facilities. So in my case, I don't have an emergency theater. So I mean, that statement, that is the end of the game for the most of the people. If you don't have an emergency theater, what is the purpose of a neurosurgeon, right? So end of the story. Anyway, still it's not finished, right? So lack of ICU beds, yeah, it's a big problem for us. And intraoperatively, we have lack of instruments. Sometimes the instruments are faulty, so which does more harm than good. And lack of manpower, very minimal time. very minimal medical officers to assist you. And post-operatively, no ICU beds. You do the operation, but you don't have an ICU to send the patient. You evacuate the ICH, and you can't send the patient to the ICU. The blood pressure rises, you send the patient to the ward, and he rebleeds. Sometimes you had to extubate prematurely. Sometimes you had to, even you send to the ICU, then you had to send to the ward as early as possible prematurely, because you have only 5 or 6 ICU beds for the whole hospital, which consists of 70 consultants. So suboptimal care by untrained staff or lack of staff, sometimes no beds to accommodate. You get a patient with an ICH, and the patient goes to the medical ward because you don't have beds in your ward, in your neurosurgical unit, and the physician call you and ask you to take over the patient, but you don't have space to take over. And the patient deteriorates, you get the patient in the theater, and anesthetist says no ICU bed. So what are you going to do? So you let the patient die. You can't transfer all these patients to whatever the nearest tertiary care center, because it's not practical. And they also don't have ICU beds sometimes. So what you're going to do, you have to think what you're going to do. You don't have ICU beds, so the anesthetist is not willing to intubate the patient. And even you do the surgery, where are you going to put this patient? You just send the patient to the ward. I mean, most of the time I had to do tracheostomy in these patients. So many problems. So, I mean, you're under so much stress, unlike a neurosurgeon from a different part of the world, or from an affluent part of the world. So it's been a real struggle and real difficulty. And also the most important thing, no emergency theater for the post-op complication at night. So for me, I don't have an emergency theater. So I say, for example, I do a brain tumor and the patient bleeds at night. So I don't have facility to reopen because I don't have at night. So what am I going to do? So I think for most of the neurosurgeons, so that's the end of the story. So if you don't have emergency theater, so you can't do emergency cases. You do routine, but you don't have a theater facility to open up if there's a rebleed. Say, for example, for a meningioma. So it's been a real stress and real difficult and a journey. So no proper rehabilitation, premature discharge, criticism from others, as always. It's really difficult. But
excuse me, Sarath.
Yeah.
We're having problems with the audio. Sometimes it disappears. Is there any way you can put the microphone close to your mouth?
Sure. Right.
Yeah, it seems to be disappearing when you turn your head. So
give me one.
Yeah, okay. It's worth a delay. And Francisco, you got to be bold and interrupt, especially when it hurts the experience. Go ahead, Sarath, try it.
Yeah, I think you can hear me now, right?
Yeah, that seems to be better. Okay.
Right. Okay. Right. So yeah, as I said, the ship is always safe at the shore, but that is not what it is built for. So you can always stay at the shore, but that's not going to work. So before I get into the cases, so these are few advices to juniors, to residents, especially in third world countries, like how to tackle complicated cases with limited resources. So I think all of you must have an insight on your capabilities and skills, and you should know what you can achieve with what you have got. And second, as I always mentioned, should not try to be overconfident or heroic. And very important, you should thoroughly study the 3D anatomy of the lesion, because you have to depend more on your clinical instinct rather than on investigations. And you should have a thorough knowledge on the complications of a given procedure, and you should have a clinical experience for that. And you should anticipate complications, and you should be prepared with the solutions if complications do occur, because you can't send the patient to your colleague or different center if complications occur. And always remember, Always.
Excuse me, Sarath, it's
Yeah.
still doing it, unfortunately.
Is
I
that
don't
so?
know, what, is there anything we can do to make your sound more consistent? Let's see, let's play around. It's worth the effort. It's worth the
Yeah.
effort. So
Just
let's just take, take a few minutes and figure it out.
Yeah, sure. Give me 1 minute.
Yes, or if you can try to connect an hearing aid, and maybe this solution the problem.
That's the ultimate possibility, but I think we can try some other things. I think he's fiddling with it now. Possibly getting, you know, if we were really diligent, we check this before the webcast. But when I'm not that diligent, I'm just worried about getting it together. Thomas, I think it's a microphone on his camera probably. You think that's what it is, Francisco?
I'm sorry?
I think that's a microphone on his camera, because I don't see an external mic.
Yes, I think that the camera. But
Yeah, I think it's a built-in mic to his camera. Just hang on, everybody.
Yes.
He may be getting a headset or something.
Maybe he's looking for the
Can you hear
headphone.
me now, John?
Okay.
Can you hear me now?
Yes.
Is it better or?
Yes, it's good
Better.
now. Okay, we'll monitor it. Okay, we'll let you know if it's not. Okay, but right now it's great.
Right.
Okay, thank you.
Right. Okay.
Right. And as I said, it's always better to halt the procedure rather than risking the patient's life in difficult situations unless it's life-saving. So always you should never do harm to the patient, and you always have to weigh the risks versus benefits. And don't embark on procedures if you are not confident to manage the complications. So that is the ultimate advice I can give you. Right. Right. A smooth sea never made a skilled sailor. Right. So with all what I have got, if I were to think in a limited what you call in a limited protocol with what I have got with the very limited resources, I would not have achieved, and I would never have done the cases which I'm going to show you today. So my advice is, sometimes you may not be able to do great things. So if you can't do great things, do small things in a great way. And also, if it works, don't touch it. Not always, most of the times. Right. So this is I'm getting into the cases now. So this is what I have got. These are the fine instruments in my armamentarium. That's all. I don't have anything else apart from the drill and the microscope. And I have got these tube holding forceps, very few fine suckers. So it's very difficult to control most of the times. Fine scissors, just one hook, one just micro dissector, and that's all for the brain surgery, and the drill. And I have the Kusa, but I very seldom I used it because it's most of the times it doesn't work. So it's a nuisance, right? So I'll be showing you some cases, but I'll be very quick through the slides. So I know John is most of the times getting and coming up with big guns in neurosurgery. So So I'm a relatively less experienced surgeon, so I'm not going to give you a lecture, or it's not going to be highly educational. So just listen to my presentation as if I'm telling you a story, right? So just a simple case, right? Doing small things in a great way. So this is a very small tumor, small meningioma. You can see this patient presented with intractable seizures, not controlled with medication, and the CT shows this small tumor with the contralateral sensory disturbances. So that's why I decided to operate. So this is not a big thing. This is a very small thing. Just wanted to tell you that you don't have navigation. So you have to be very accurate with your craniometric points, because you don't have, for me, I don't have time to go to the radiology department all the time and do the measurements. So I do measurements at the theater with the CT. So you have to be very accurate with your craniometric points. Otherwise, very easily you can get lost, especially with these small tumors, right? So a small craniotomy done and tumor removed, not a big thing. And patient's symptoms resolved, right? So these cases, I think I have shown you in my previous lectures as well, previous presentations as well. 3 big olfactory groove meningiomas. I didn't have the facility of MRI at that time, so all these cases were done without MRI, only with the CT. So you can see large tumor, giant tumors with lots of perilesional edema and pile invasion. I mean, a lot of edema in the surrounding pia. So in these type of situations, you know, these are, I mean, complicated cases, sometimes complex cases, because of the involvement of the important structures, the major blood vessels. So you have to always think about the possibility of inadvertently damaging the surrounding structures like the optic nerve, the olfactory nerve, and the anterior cerebral vessels. This is the post-op CT, the immediate post-op, and this is the CT after 1 year. And you can see there is no recurrence, so no residual. And this is immediately post-op, and this is after 1 year. So you have to be thorough with your anatomy. And you have to have a clear 3D structure, a clear 3D view of the anatomy, especially when you are operating without an MRI, where you have you haven't got much idea about the planes and the involvement of the crucial or the critical structures. This is the second case. This patient presented with low GCS. And again, giant tumor, olfactory groove meningioma. So I had to operate then and there. So as expected, it was severely adhered to the anterior cerebral vessels. You can see the anterior cerebral vessels here, carefully preserved. And this is the immediate post-op the CT. And this is her, no deficit, absolutely fine. Presented with psychological disturbance, with about to get her family disrupted, but everything went fine. And the psychological abnormality was because of the tumor most of the time. So all these 3 patients had psychological abnormalities, problems with their behavior because of the frontal lobe involvement. The third case, I think it's a 63-year-old female. She had a lot of perilesional edema. This was a difficult case, as I can remember, because the consistency of the tumor was very rough, very tough and firm. But she did very well as well. I saw her in the clinic few months back. She was fine, but she didn't come back for a post-op MRI at 1 year's follow-up. That's the problem with these patients. It's very difficult to convince them for surgery as well, and as well as for the follow-up. Most of the times we lose these patients during follow-up. So it's very difficult to follow these patients up. Another case, not complicated, not much complicated, but I'm presenting this case to you. This patient is a young lady, 40 years old. Again, she presented with psychological disturbance and epilepsy, seizures. And we did the CT, and we told her that she's got a lump in the brain and it has to come out. She was not happy to get it operated, and she wanted to try the other treatment. So she was scared of anesthesia, and she was scared of the scar. So I had to convince her, and did the surgery with say a limited or a mini craniotomy, with a limited craniotomy, and she did very well. So this is the post-op X-ray, and I saw her last week in the clinic. So we were planning to do the follow-up CT for her. Another lady, 80 years of age, with so many comorbidities, ischemic heart disease, so again seizures and psychological disturbance and severe headache. And she had this meningioma. So I decided to operate her with again with mini craniotomy with eyebrow incision. Unfortunately, I couldn't find a picture of the patient with the small incision and the scar. So you can see it was done with a small incision and a small craniotomy, and it didn't take much time. So without any complication, she recovered. She didn't get any complications, no CSF leak, and did very well. Another one, convexity meningioma. She had gone to so many places to get this cured by other means, not only by surgery, but other means like native treatment and Ayurvedic treatment and etc., and came to me, and I had to convince her very hard that this needs to come out. And she was very anxious, and very anxious actually. So the tumor was removed without any problem, without any deficit. Very happy. Again, she came to the clinic, and we are planning for the post-op 1 year radiological follow-up. Unfortunately, I mean, all these patients, even though we routinely do a post-op MRI scan or the contrast CT at 6 months time, and then at 1 year's time, they didn't turn up at 6 months. As I said, this is the difficulty in following these patients up, especially in this part of the world, right? I think I have shown this patient to you before. This is a patient with a large meningioma. Again, it has been there for years and years. She didn't want to get it operated because of the fear of the complications. And again, I had to convince so much time. So I had to convince her very hard so many times that surgery is the most fruitful solution for her. Her main problem was headache, vertigo, and weakness. Weakness due to the brainstem compression. So I was pretty sure that I was not going to take this tumor completely out with my armamentarium and with the resources available for me. So what I wanted to do is to release the pressure on her brainstem. So you can see it's a large meningioma, and believe me, it was rock hard, right? So it was really hard, and CUSA also of no value. So I removed as much as possible, releasing the pressure on her brainstem, and she didn't get any nerve palsy. And I think it served the purpose, right? So I made her life comfortable, and she is regularly visiting the clinic and regularly following up, and she's for the up to now, she is happy and she is devoid of any major symptoms, even though she is having on and off few symptoms, but she's a happy child. Right. This one also, I think I have presented before. 14-year-old girl with craniopharyngioma presented with loss of vision. So this is the contrast, the non-contrast CT is the contrast. So I had to operate without an MRI because we had no MRI at that time, and she was not willing to get it done with by a different hospital because of the COVID issues at that time. So she's an orphan, and this is the immediate post-op. This is a few weeks back. This is the 1 year, not actually 1 year, this is 6 months post-op MRI. So we have got an MRI. So this is the MRI. So there's minimal residual of the third ventricle. It doesn't matter. Child is doing very well. So I didn't want to actually remove this, the whole tumor, especially at the third ventricle. Right. So she's doing very well. So that was an example of identifying your limitations, right? So your limitations and your capabilities and what you could achieve with what you have got without making the patient's life risky, right? So this case I did 2-3 days back, cerebellar tumor, 18 years old boy coming with severe headache and gait disturbance. So we identified this tumor with hydrocephalus. And the radiologist have reported it as a hemangioblastoma, but I thought it's more like pilocytic astrocytoma clinically, intraoperatively. So we inserted the VP shunt initially, and he was operated. He had to wait more than, I think, around 4-5 weeks. He had to wait 4-5 weeks to get an ICU bed before the surgery, because initially I operated on some complicated cases without an ICU after getting the consent, after explaining the patient and the relatives in life-saving situations. But nowadays, I have decided not to go ahead with that protocol. Most of the time, especially for the routines, right? And so he had to wait more than 1 month in the ward to get an ICU bed because of under the circumstances. So this is post-op. So this is him. No deficit, is fine, right? This is actually an interesting case I wanted to show you. This is a woman, a lady from Thailand, with very little knowledge in English, and she came with intractable seizures, epilepsy, and headache. And her CT shows this one. You can see the calcification here, and it's a calcified mass. So I thought it could be a calcified maybe tumor or an AVM, etc., etc. So since she had very little knowledge in English, we had problems with communication without any doubt. And she gave us the history of something like a bleeding in her brain. So we thought it could have been an aneurysm, it could have been an AVM rupture. And she said something was done in Thailand through the femoral vessels. So we thought we thought it could have been something like coiling, but we were not very sure. So we did the angiogram and we did the MRI as well. So the angiogram, this is the one we got it. This is the one we did that from our hospital. And it came as appearances suggestive of an onyx cast with absence of contrast filling, no AVM in the left posterior parietal region. So our radiologist thought that it could be an onyx cast in a previously known AVM. But I was a bit reluctant to believe that. And I thought the possibility of a tumor as well. So I wanted them to get the angiogram and the MRI from an outside hospital, a private hospital as well, because they were willing to get it done outside. Because there are a few reasons. Because the CT machine we are having is only a 16 slice CT machine. So most of the times, especially for CT angiograms, it's not very good, not very sensitive. So the CT angio in full-blown subarachnoid hemorrhage, it comes as negative. But when you do DSA or when you do CT angiogram, when you repeat it outside, it becomes positive. So it has been happening for a long time. So that's the problem when you don't have a dedicated neuroradiology team and the facilities. Our radiology guys are superb, but it's out of their control. So they are working with the maximum capacity with the given circumstances, under the given circumstances, and with the resources available. So this is what the angiogram showed. So I thought of getting a biopsy or doing a maximum, whatever maximum surf resection, because it was close to the motor area as well as the speech area, the language area. So absolutely, I was not going to take the whole thing out. So I did whatever the possible resection, and it came as they said initially. The initial report said the features fever a radiological diagnosis of an arteriovenous malformation with coexisting meningioma oligodendroglioma. But then the final report came as oligodendroglioma, which actually was my gut feeling, rather than what you call arteriovenous malformation. So that was an oligodendroglioma. So interesting case. So that's why you have to be always think, and you need to have your clinical sense sometimes in tricky situations. So we send the patient for radiotherapy, and she's doing very well. She didn't get any weakness, but she's mildly dysphasic, but that improved with time, and she's doing very well now. This is just one case I want to show you. So on and off, you get these type of patients. This patient had a big tumor, probably a meningioma, and we wanted to operate, but she refused, and she went back for native treatment, and she came after a few months with a GCS of 4, and she arrested. She had respiratory arrest, and she died. So you can see the herniation, the infarcts, PCA infarcts, everything is there. So these type of patients are also there in this part of the country, and it's very difficult to change their beliefs and attitudes. Right. Now I'm going to show you a few cases that actually ended up very sadly because of unavoidable circumstances. This is the girl with neurofibromatosis type 2. I'm sure I have talked about this before. So she had 3 tumors, 3 considerably large tumors on her spine. One in the cervical spine, one here, and one there, and all were operated by me. She came actually with a she presented to me with an upper limb power of 1 and a lower limb power of 2, and I operated on her sequentially throughout the spine, and she regained her upper limb power to 5 out of 5 and a lower limb power of 4 out of 5, even though she could walk with difficulty. And finally, I did this CP angle, the schwannoma, and it was removed totally. And actually, it was the time where the COVID hit the country very badly, and we had so many issues with ICU. and she was very rapidly worsening. Her symptoms were worsening at that time, so we operated her, and the surgery was successful. Successful means we extubated her. She didn't have any deficits, no facial nerve function, no facial nerve palsy, but unfortunately, she got COVID, and she died because of COVID pneumonia, which was very unfortunate, and very heartbreaking to the parents. Right. Another case recently admitted, recently came with a GCS of 5. And the patient had respiratory arrest at the emergency treatment unit. And the CT shows this. I'm sure you can see a large tumor here. The posterior facet tumor, probably a meningioma with the calcifications and everything. And had hydrocephalus. So you can see, I'm sure you can see the tumor, it's a large tumor, probably going all the way towards the tentorium, and maybe the sinus as well. So we inserted an EVD, thinking that she would improve, and we fortunately had an ICU bed. We tubed the patient. She came around 5 p.m. in the afternoon, and we soon inserted an EVD and the local anesthesia, and we sent her to the ICU. And the next day, I had to operate on her without any further investigations because she was not in a good condition. And this is what I did. I removed the tumor. The maximum I could do at that time without any investigations, without any further investigations. A little bit of residual here. I don't want to, I did not want to go so far up. And this is what happened after 2 days. We extubated her. She was GCS 15 out of 15. And she had a little bit of generalized weakness, but she could stand, and she was sent to home. She was sent to the ward. But unfortunately, what happened after that was very heartbreaking. We mobilized her, but because of the generalized weakness, she couldn't mobilize very well. DVT stockings applied. We didn't give her the prophylactic enoxaparin because it was only post of day 5, and she was not very obese. This is what I don't know why I can't play this. She developed pulmonary embolism, and she died, which is very unfortunate. I'm sorry I can't play the video here, but I'll show you at the end all the videos after this one. And another case which there was a bit of complication. A 35 years old male with this tumor with supracell extension, a pituitary tumor with supracell extension, and with rapid loss of vision. His vision deteriorated after the admission very rapidly. And this is his MRI. I don't have an endoscope to operate. Although I was trained in endoscopic skull-based surgery for around 8 months. So all the pituitary surgeries were done endoscopically at King's College and Queen's Square when I was trained overseas. But I don't have an endoscope here. So I thought of, because of the supracell extension, I thought of approaching this case transcranially through the peritoneal approach. And I did the surgery. And I don't know why I can't play this video. Sorry about that. I will try to show this at the end of the presentation. So this patient actually developed subgaleal hematoma, as well as I think I inadvertently damaged the branches of A2. And there was a little bit of ischemic area in the right frontal region, but it did not cause him any deficit, fortunately. And he actually regained his vision and improved very well and was sent home. So that is one situation where we encountered the complications or the difficulties. So again, I'm showing you a case where where I got into trouble, or where the patient developed some complication, a little bit of complication. You can't say it's life-threatening, but they developed the complication, but they recovered well. And I think we need to talk about complications and difficulties, because most of the time people do not talk about the complications, and they only come up with the absolutely fine cases and absolutely successful cases without complications. But I think we should talk about complications, and these are the type of cases that we can learn most of the time. And this is another case like that. Sphenoid wing meningioma in a young patient, 25-year-old male, operated. And at the end, I think when I entered the cavernous sinus, there was sudden cerebral edema. So I had to hold the procedure, and I had to leave a little bit of residual there. So that's not a big deal. So I stopped the procedure, and I kept the bone flap and I preserved it in the abdomen, in the abdominal fat, what I usually do, since we don't have the facilities to preserve the bone flap in the refrigerator. And but patient did very well. Patient didn't have any deficit. And there was a bit of residual on follow-up MRI, and we sent him for a radiotherapy. And up to now, we did the cranioplasty, and he's fine without any deficit. So that is one case that you have to hold the procedure. You have to stop whenever you think continuation of whatever your procedure is not suitable or not very safe for your patient, especially under the circumstances especially when you are practicing at a periphery with minimal help and minimal resources. Another case, this was done recently, a large sphenoid wing meningioma, young female, 37 years of age, rapid loss of vision, again rapid loss of vision, and her weight was around 106 kilos, and she was only 4 feet and 8 inches of height. So she had a very large BMI index, and but unfortunately, since she had rapid loss of vision on her right eye, we had to operate her. And I warned her that she had to actively engage in preoperative physiotherapy and chest exercises, because I had this bad gut feeling that she would. She is a high-risk candidate for deep vein thrombosis and postoperative pneumonia. So we operated on her, and I think I did the near total resection, except at which was very firm, and again a very tough firm tumor. And so there was some post-op superficial hematoma, subgaleal hematoma, which I had to remove. So I decided to remove it, and again I did not put the bone flap because of the considerable postoperative edema. But she was fine. She was GCS 15. She didn't have any deficit, and her vision improved. And we sent her home thinking that we can get her back for the cranioplasty. And after 1 week, she came back to the medical ward with shortness of breath. Histologic MS and meningioma grade 1, and you can see the build of the patient. I mean, you can imagine. Unfortunately, I don't have a photograph of the patient. She was very, very obese, and unfortunately, again, she developed deep vein thrombosis, pulmonary edema. On top of that, she developed pneumonia, and she died. So, few unfortunate cases where you operated a very hard for hours and hours, and ultimately, you lost your patient due to totally unavoidable or totally unrelated. You can't say unrelated. All these cases, I wanted to share you that these things happen, especially when you are working in peripheries and where you don't have a superb rehabilitation protocol or a post-op post-op management environment. Right. So let's talk about something about intracerebral hemorrhages, right? Because I have been practicing the evacuation of deep ICH for the last 4 or 5 years, right? So I know it's a controversial issue, right? I know the stitch trial, stitch 1, stitch 2, and all this. So we have read, we know about this, but talking about the deep ICH. So initially, I know most of you will not agree with me, and most of you will say, if you get a deep ICH, don't touch, right? I did the same. I didn't touch unless there is an indication. There is a life-saving indication for me to evacuate the ICH, the deep ones. But when you practice in the periphery, especially when you don't have when you don't have enough bed capacity to accommodate these patients, and you don't have ICU facilities or HDU facilities, and when you can manage these patients conservatively, initially the patient's GCS is fine, but after 2-3 days, patient GCS drops, they die of aspiration. And I also thought that I need to come up with something different to stop this. So what I do, superficial hematomas, right, as stitch trial mentions, I do evacuate, and deep ICH, especially on the non-dominant side, extracapsular, I evacuate. And also I'll show you as I gone with the cases. So this is one case that I did 3 years back. So actually this is a superficial ICH, right? And I evacuated it because the patient GCS dropped. And all the cases I'm showing you, all these patients GCS, the initial GCS, the presenting GCS to me as the neurosurgeon, when I decided to operate, was less than 8. And that's why I'm showing this to you. I'm not showing you the cases I did with a GCS of more than 8. And also remember, I only operate if there is an indication for urgent evacuation only. So I don't unnecessarily operate on deep ICH. And routinely, I don't have facilities to do an angiogram. Especially, we do angiogram selectively if it is absolutely necessary. And if I'm absolutely sure that is a hypertensive beat, I don't do angiograms. So this one presented with a GCS of less than 8, I think it's GCS 6 or 7. I operated, and this is 3 years back. So a little bit of a bigger craniectomy, and patient went home. Patient had weakness, but patient survived, patient went home. So what the problem here is, when you work in the periphery, you don't have ICU beds. So what are you going to do? So in that case, we know most of these patients, because of low GCS, they die of aspiration. They die of respiratory problems, post-op pneumonia, aspiration. That is the main enemy of this type of situations. So what I did was, if it was absolutely necessary, I did early tracheostomy. I knew it's some kind of a big undertaking for the patient, but that was life-saving. And I have so many evidence to show you that it saved my patient's lives. So patients survived with tracheostomy. We send the patient to the ward. And if we have an ICU, I send the ICU for at least 8 to 12 hours and then manage the blood pressure. And then they send to the ward. I know it's premature, but that's what they could offer to us. And we do tracheostomy and patients go to the ward and the patient survived. And most patients, we were able to close the tracheostomy before 2 weeks and they went home. And I'm having so much evidence and I'm preparing, I'm getting ready for that. And this is another case, right? And then as time goes on, I decided to make the craniotomy. And I reduced the size of the craniotomy and I reduced it to a size of a burr hole, finally. So you can see this is a very small hole to a small hole. I was doing it again. Patients survived. All these patients survived and all these patients are still alive. So I'm only showing you that cases. And this is another case, a 66 years old female. Her GCS was 5, I can remember. She was on warfarin. And the anesthetist was not actually happy to give anesthesia for this case even. And so I had to a little bit of a hot discussion. I can remember I did it 2 years back, and this is the post-op. It was again done with a small opening. This is the pre-op. You can see the date was 20th of November. And this is the post-op. You can see the date 21st of November. So this is the immediate post-op on post-op day 1. And this is her. You can see this is 4th of December. So 2 weeks and she's walking. And we didn't do the tracheostomy for this one. She remarkably recovered. And that's why I'm showing this to you. Another case, again, a deep ICH, non-dominant. So I had low threshold of operating if GCS dropped and if there is mass effect. I was only operating, and I'm operating, as I said earlier, I'm only operating as a life-saving measure. If patient's GCS drops, otherwise, no surgery. Right. So the only difference is I'm doing it through a small hole. I don't have the endoscopes, exoscopes. I do have nothing. But so what I'm trying to do is you minimize the mobility of the craniotomy. You go through a small hole. I know it's difficult, right? So it takes some time. It has a learning curve. It takes some time for you to realize what you can achieve. So it's not essential to take all the clot out, right? You just need to release the pressure, right? And this is at the presentation. So we didn't operate. This is after 48 hours. The hematoma expanded and GCS dropped. So I decided to operate. So this is the pre-op. This is the post-op. You can see it's a relatively small opening. So as I said, you can't take the whole clot out, right? So what I do is I make a small holes, make a small opening in the cortex, and I deepen the cortical window and I go through it. I'm just using the bipolar and the sucker, and I'm inside the clot. I go inside the clot and I remove the clot and I let the rest of the clot to come into the center of my whatever the working cavity. And sometimes I use the handheld, what you call the snake retractor, to gently retract and take the surrounding clot out. And I think we'll talk about this later. I can show you some videos of mine in a different occasion. So I will just go through only the cases today due to the time constraint. So this patient did very well. So this is immediate post-op, and this is after 2 weeks time, he went home. You can see, I don't usually, I don't sometimes even fix the bone flap. I just keep it floating, and that's enough. That will, even you can take it out. There is, no necessity to keep the bone flap. And all these patients, they survived. And you can see another one. I can give you so many examples. See the opening, very small opening. Took it out. Patients went home. Some patients need tracheostomy, and some patients did not. This is actually 2-3 years back. This is initial stages of these deep ICH evacuations. Another one, last year, you can see large ICH. See the opening, small opening, and you can see this is the pre-op. You can see the date. It's 10th of February, and this is 11th of February. This is immediate post-op day 1. We usually get a post-op day 1 CT, and I'm showing you only the immediate post-op CTs. Another case, you can see again hypertensive ICH. You can see the opening was a bit different here. I had gone through a little bit of above a trajectory of the trajectory was a bit high in this case, and see, it's a small opening here. You can see that, and this is after 2 weeks. You can see the dates. This is 25th of August, and this is 10th of September. This is 2 weeks after. This is the patient, as you expect, weak on the right side, but walking with assistance now. He's talking. He was initially dysphasic as expected. He survived. All these patients survived. Right. So you can see the same patients, the opening, small, very small opening. It's just bigger than a burr hole. Another one. This was actually this patient. I didn't want to operate initially because there was no indication to operate, and patient rapidly deteriorated, and GCS dropped, and it was a Thursday. And as I told you earlier, we don't have an emergency theater. I don't have emergency theater, so I'm only having theater facility from 8 a.m. to 2 p.m. from Tuesday to Thursday. So I'm operating only within that time frame. So all these emergency, whatever, the ICHs, EDH, SDH, all these spines and all these tumors, I'm operating only during that time. Which is, you must be very wondering, you must be surprised to hear that. And all these cases were done like that. So this was a Thursday, and I knew there was, I can't operate on Friday or during the weekends. And this patient deteriorated because of the expansion of the ICH. What else? Electrolytes normal, other things normal. What else? So I did not want to repeat the CT. Again, it takes time. I directly got the patient to the theater. There was no ICU beds. Anesthetist said, I can't anesthetize the patient because probably we won't be able to take the tube out. So what I did, sedation, under sedation, put a burr hole and removed as far as I could. Right. So the patient survived. And so the hematoma must be larger than this at the time of operation, at the time of surgery. And I didn't want to take the whole thing out. And you can see, this is him. Did a tracheostomy closed. He went home at 3 weeks' time. Another one, large ICH, small opening. As I said, no need to take out the whole, the hematoma, right? You can see the opening here, small opening. 2nd of September, this was done at night, the post-op CT. Patient went home. Same thing, another patient, right? There was no indication for surgery initially, small clot. Same thing happened, patient deteriorated, no time, right? So same thing, did the burr hole under sedation. I know. So most of you would not agree with me, right? So I know the risk. So what I do, I always talk to the patient's relatives, get the consent. I explain this is the situation, because see how many patients we always get. And you can't always be transferring all these patients to whatever the center, right? It's not practical. So you have to find out a solution for that. So that's what it's all about. And it's not just transferring the patient, or it's not just managing all these patients conservatively and let them die. So I have seen patients die. So, I mean, with this, I have saved so many lives, whatever the people say. So this, we have enough evidence. And again, it's removed with the burr hole, patient survived and patient went home. And now she's walking. Again, same thing. Again, same thing. No indication for surgery initially, managed conservatively. Then they referred to us again, right? I mean, I was operating one case and they referred to us. So we always ask them to, these ICH patients, we always try to keep them, I mean, on IV fluids within the first 24 hours because of the deterioration. There's a risk of deterioration. But most of them, I mean, in the medical wards, they feed these patients through NG and even sometimes without NG. And sometimes it's beyond your control, so they aspirate. Most of the time they aspirate and they die. And this patient also, they deteriorated, probably due to expansion. Again, same thing I did, right? I didn't want to take out the whole thing. And she, this is him. You can see this was 25th of August, and this is 10th of November, 10th of September, even 2 weeks after. He was walking with 8, right? So I can give you so many examples, so many cases. Again, same thing. You can see very small opening, taken out, right? This one, again, I couldn't find the pre-op, the initial ICH. It was a big one as far as I can remember. Young patient, doctor's sister, and she's walking, and now she's walking and talking, again done with small burr hole, right? A different case, again an ICH, but 5 years old. And in this case, you have to be careful, because it's very unlikely to be an hypertensive. And that's why you need your clinical sense. As I said, you need to use the investigation, whatever investigation available. And you have to be tactful as well. So definitely needed an angiogram. There was some blood in the sylvian fissures. So I thought it would be could be an arteriovenous malformation. We did the angiogram. Angiogram showed nothing, no arteriovenous malformation, but I operated on him because he presented with the JCS of 7 and big craniotomy, right? Big craniotomy, right? You had to think about it. You had to be prepared. You can't do burr hole here, right? Big craniotomy and clot evacuated, and it was an arteriovenous malformation. And patient went. We did a tracheostomy for the patient, and we closed the tracheostomy before 2 weeks, 10th day, and we sent him home. Right. So you had to think accordingly. Right. I would like to discuss and show you a few aneurysm cases. As I told you, our CT angiogram machine is only CT is 16 slices. So most of the angiograms, see, very thick subarachnoid blood, very heavy SH. Sometimes it comes as negative, not sometimes, most of the times. And this is the best my radiology colleagues can give it to you. So I don't know whether you can appreciate an aneurysm here. It's very difficult to see, right? And this is the reconstruction. It was an IC aneurysm, right-sided, clipped, without deficit, patient went home. Unfortunately, I don't have photographs of these patients because I was not bothered to take a photograph. This is a few years back. Sorry about it, because I usually take photographs then and there. This is another case, 56-year-old female. This is what they could produce from the angiogram. I think you can see the ACOM aneurysm here. It was a large aneurysm. I have the video, but I don't have time to show you. I show you at a different time. So ACOM clipped, no deficit, went home. See, another one, 74, 67, I can remember, yeah, 67. I don't know whether you can appreciate the aneurysm here. PCOM aneurysm, right side, PCOM aneurysm, clipped, heavily atherosclerotic internal carotid artery, and the other vessels heavily atherosclerotic. And she developed post-op vasospasm and a bit of ischemia, but it didn't cause any deficit. Another one. Sorry, I can't play this one. Something wrong with this media player. So this is a young chap, 35 years old, presenting with a very bad CT, a very thick subarachnoid hemorrhage, and high Fisher grade, and presenting with low GCS and with low blood pressure as well, a highly unstable patient. And we did the angiogram. This is actually the angiogram done in our hospital. It didn't show, I mean, much. I went to the console and tried to visualize, but they said they could see something in the anterior communicating artery region, but I was not convinced. And so what I did was I did the decompression. I did a decompression initially because the patient was not stable and patient was deteriorating. So we did an EVD, and I had to do some decompression. I went on the left side because I thought of going ahead with the aneurysm clipping if there was not much brain swelling, but there was so much swelling, and I thought it's not advisable for me to go ahead. And I just did a decompression, and I put the bone flap as I usually do. I preserved it in the abdominal fat and came out, and patient improved. And I sent him for another repeat CT angiogram outside. So this is done. This is what he came up with at the private sector. So you can see the difference between the angiogram from the government hospital in my center and the private sector. So this is the angiogram done at the private sector. You can see it's an aneurysm, bilobed aneurysm, difficult one because the two lobes were orienting. The orientation was in two different planes, and I knew it was a very difficult one. So same approach, clipped it. Unfortunately, I put the clip on the bigger one initially, and I was about to clip the other one. There was a tear in the neck, and I had to struggle so much time to get the control and to get the proper clipping, because I didn't have I don't have fenestrated clips, so you know, it's just basic clips I'm having. I don't have much selection, much variety. So, but I was able to tackle the situation. Fortunately, he didn't get much deficit except this post-op vasospasm in the right frontal region. So, fortunately, he survived, and now he's slightly dysphasic initially, but now he's talking. But he got a post-operative infection, chest infection. He's still in the ward. Now it's being a month. He can talk, he can walk, and it was a real difficult case. Another case. Again, a young female. So you can see this is the CT angiogram done in our hospital. I don't know whether you can appreciate the aneurysm here. This is done outside. So see the difference between these two. It's a huge difference, right? So it's very difficult. And as a neurosurgeon, for you to preoperatively determine. And neurosurgery is something that you need to preoperatively plan. So especially thing like aneurysm, you can't just do it. You can't just open up it. You can just go in and you can just flip it. You have to have mentally, you have to prepare, and you have to do a lot of your homework. But the problem as a neurosurgeon in a periphery in a country like this, and you prepare for a surgery, and next day you come and you plan for the surgery, suddenly your anesthetist, there is no ICU bed, and everything is blocked and shattered. And then again, unexpectedly, sometimes you get an ICU bed, and then sometimes you may not be prepared mentally for that. So it's a real difficult task, and it's not easy. And especially during these critical situations. And you can see, you can't always keep transferring these patients to different hospitals. It's not practical. And it's, even the whatever the center we are transferring, they have so many cases. They have their own, draining areas. They have a lot of patients, and they don't have ICU beds. They don't have capacity. It's not the solution. It's not the solution. So before appointing a neurosurgeon to a certain center, you have to provide the facilities. Otherwise, there is no point in appointing the neurosurgeon without the facilities, making the life of the neurosurgeon hard, and making the patient's lives at risk. So it's a really pathetic thing. It's up to the the rulers in this country, and not in this country as well. I know it's a problem in most of the countries, the third world countries. Not sending another neurosurgeon to whatever the center is not going to solve the problem. It's going to create more problems, right? So for as an example, for me, I'm having it is the only neurosurgical unit for the whole province, which drains 3 million population. But for the whole unit, I don't have a separate ward. I'm just going here and there, right? Because of the COVID, just sent to a neurology ward sometimes to the orthopedic ward. It's been really frustrating. And only 3 beds available for the female for the whole province, the only neurosurgical center, and only 5 male beds. So how can you how can you operate these patients, and where are you going to put these patients? And most of the times you have to wait months and months for ICU beds. Some patients die. So we refer some patients, we transfer some patients. Most of them, they don't want to go there. And most of the patients, they want to get operated, especially the tumors and gliomas. They go for native treatment. So you have to, convince them very hard. And once they're convinced, and then if it gets late, and if we transfer the patient to a different center, most of the time they don't want to go there, because they say then there is nothing, they don't have anyone there, and they don't want to go to an unknown area. So it's difficult for them to travel. So many practical problems which most people do not understand. So it's not easy. And remember, transferring a patient is also not that easy, right? So it's not straightforward. So many issues are there, so many problems. So you had to tackle all these problems, not only the aneurysm, right? You had to think about all these things, right? So it's not a simple thing. It's very hard. Life is very hard as a neurosurgeon. Most of the times you end up in frustration, right? Okay, see again, as I was explaining. So see the difference. This one is a middle cerebral artery aneurysm, again a bilobed one. This was done at a private sector, and patient did very well. So she didn't get any deficit. So this patient didn't want actually to get the surgery done at the government sector. I don't know, the only case I'm showing, which I did at the private sector. All these cases I'm showing you, I have shown up to now in all my webinars, are done at government sector, not at private sector. This is the only case I shown you done at the private sector. Right. And another case, again, middle cerebral artery aneurysm, similar cases. So these patients, they presented to me 2 days apart, similar type of aneurysm, same age, and clipped without any deficit. Another one, MC aneurysm. I don't know whether you can see it here, right? This is the aneurysm. Even you go to the console, this is the best they can provide you. It's not the problem with the radiologist, it's the problem with the resources you are given with. Right, okay. That's all about aneurysm cases. A few cases to show you how difficult and what are the difficulties we encounter and how do we tackle all these patients. I mean, all these cases. It's very hard, as I said. So you had to think in so many paths. I mean, so many ways you had to think. Not only because the investigations will not lead you to a definite and unequivocal pathway. So you had to think about so many, you had to anticipate so many problems, and you had to anticipate different things. So you had to have a thorough knowledge of your anatomy, and you have to determine whether you can manage this case without killing the patient, and then go ahead with the case, right? And how to troubleshoot. So all these things you have to know. And I have been doing all these cases with whatever whatever the armamentarium I have shown to you before, right? So let's get into a few spine cases quickly before we finish it. So this is a very interesting case I wanted to discuss, a case of neurofibromatosis type 1. And can you see, she presented to me with back pain and severe headache. So can you see the back? Can you see the spine? It's severely deformed, right? So the spinal deformity associated with dural ectasia and neurofibromatosis type 1, which is a very rare case. So she had dural ectasia and she had low pressure headaches, probably because of this. And so you can see the dural ectasia, and this is very unfortunate. So this is in 2005. She underwent investigation, the MRIs, and she had seen few surgeons, 2 or 3 neurosurgeons, but she was not given any advice on that, which was very unfortunate in my country sometimes. And she didn't know anything about her disease, right? So I knew that I was not going to I mean, reconstruct this spine, because I was not in a position to reconstruct this. I tried it. It was like eggshell. So it was not what you call it, was not fruitful. And what I did was I did the lumboperitoneal shunt. Right. If you go through the literature on these type of cases, you will see there are few options we are left with. One is lumboperitoneal shunt, and sometimes people do laminectomy and they put glue. So I did the lumboperitoneal shunt to reduce the pressure and to reduce the symptoms of the low pressure headaches, and actually it did work. So this is the shunt, and actually it did work. And her symptoms, her headache, not the back pain, her headache responded very well. And but still the back pain persists, right? So that is obvious because of the deformity. And I don't know whether she could have offered anything at that time as well for her back, because this was one of the severe cases, and I'm sure it keeps on deteriorating. This is in 2005, and this is in 2020. So 2020. So young patient, unfortunate. Right, and this is another case. It's not a highly complicated one. This is 2, 3, 4, 5 C45 unifascial dislocation. You can see on the right side. So what I did anterior fixation, anterior fusion. She did very well, and she went home. Just to show you, recently done one. Another one, 31 years of age. Female, C1, C2 meningioma. C1, C2 meningioma. You can, I don't know whether you can see that the imaging is pretty bad. I think it's you can see clearly here. So a relatively large lesion, probably a meningioma at C1, C2, mainly on the left side. And when she was referred from the neurology side, her upper limb power was around 3 and her lower limb power was around 4. But she had to wait for some time, around 10 to 14 days before surgery, because of the issues with COVID and under the circumstances of COVID, and there were so many other cases at that time. So her power gradually deteriorated, and ultimately it was the lower limb power was very low, around 1 on the left side and 2 on the right side when I was operating, and I had to operate her before the expected date. So you can see this is the CT, this is the MRI, this is the CT. You can see it's a calcified tumor, whatever it is. You can see the calcified nature, and this is the sagittals. You can see again the calcifications. You can see here, and this is post-op. This is pre-op, and this is post-op. You can see I did a very limited. I want to do actually a hemilaminectomy on the left side to take the tumor out. So I did a very minimal laminectomy on C1 and C2, a relatively small one, and I taken out the tumor. I'll show you the video. Let me quickly show you the video. I'm sure I can show it to you. I think it's there. So this is the yeah, this is the post-op. Let me show you. Yeah, this is the post-op. 1 second. Yeah, so this is the pre-op one. So you can see she could very vaguely move her right side, and she couldn't move the left leg at all. Right. Yeah, this is the post-op. I think this is post-op day 10 or 14. Yeah, that's why I'm showing it to you. So remarkable recovery. Yeah, remarkable recovery she had. Right. Another case. Yeah, this is actually a very sad situation for this relatively young lady who was very obese and presented with severe myelopathy, severe cervical myelopathy with a very high JOA scores. And this is what her MRI showed to me. And you can see this is not only disc osteophyte, this is OPLL, this is ossification of posterior longitudinal ligament. And you can see the OPLL was severe at C2, 3, 3, 4. I'm sure you can see this. This is C2, 3 level, severe, 3, 4, and also at 4, 5, and 5, 6. So this is the whole spine. I think you can appreciate there was what you call this, the myelopathic changes, the cord edema at C2, 3 level, but not beyond that. And this is the flexion extension X-rays of her. You can't say that she had a good cervical lordosis. And and what about this one? Actually, this is a good case to discuss in detail. I wanted to discuss it with Juan, with his the American spine surgeon, with the upcoming the spine case review. It's a very good case to discuss, but I will very briefly discuss for the moment. So this is the CT scan. So this is most probably DISH, diffuse idiopathic skeletal hyperostosis. But I know for the definition of DISH, you have to have 4 contiguous involvement of the vertebrae, but it is almost 3 vertebrae. And this is the calcified OPLL here, calcified PLL, the OPLL here, right? And here the CT shows the axials, again shows the calcified ligament. See the neck, very short neck, very short. I mean, you could say there is no neck. Indeed. And if you were to carefully look at the MRI, she had a goiter as well. She had a big goiter, mainly on the left side as well. And she, apart from the myelopathy, she presented with features of dish as well, dysphagia and dysphonia as well, with hoarse voice, right? So my plan was decompression anteriorly with the osteophytes as well to relieve her dysphagic symptoms, and posteriorly as well, because doing an anterior procedure here, because I need to address the problem at C2, C3. So given the loss of lordotic curve, I thought of going for a posterior procedure with fixation, with fusion. Otherwise, you make this patient's spine unstable. And see the type of short neck she is having. Her neck was very short, right? It was very, very difficult. The procedure was very difficult. So what I did was, and sometimes it's not, I mean, it's difficult to imagine doing this case with whatever type of help I am having under the circumstances. So this is what we did. What I did the decompression from C2 to C6, and I fixed her from C2 to C6. So I inserted pars screws at C2 and lateral mass screws down to C6, right? So this is the axials, and it's not violating the vertebral artery or the spinal canal, right? So you can see the decompression done from 2, 3, 4, 5, 6, C2 to C6. This is a post-op CT brain, right? Brain was absolutely fine. But this is the tragedy. This is what happened on post-op day 1. She was sent to the ICU because of the risk of, the aspiration and the breathing problems we anticipate. Actually, I didn't want to tube her. That's because of the anesthetist's opinion. We kept her intubated for 6 to 8 hours until the next day. And she woke up with a post-op deficit. Her bilateral lower limb power was 1, and right upper limb power was 3, and left upper limb power was 1. See the edema here. See the cord edema. Initially, the cord edema and the myelopathic changes was just at C2 and C3. But now you can see it's from all the way from C2 to down to C6, where I did exactly the decompression. So what is this? This is white coat syndrome. So this is post-op hyperperfusion. I think probably the 13th case. So if you go through the literature, up to now, there are 12 cases reported, and this is going to be the 13th one, most probably. You can see the edema clearly from C2, 3, 4, 5, 6. It's really unfortunate. And really unfortunate because of the body habitus. Again, she developed chest infection. She was there at ICU for around 1.5 months. And it was very, very distressing for me as well. We never expected this. This is beyond my control. And so that's why we did all these post-op CTs, and I did post-op angios, and to see whether there is any damage, to check for the vertebral artery. And I checked one by one the trajectory and the pathway of the screws, nothing else. So it had to be this. And patient ultimately died of post-op pneumonia because you could have seen her size. Her body habitus was not very favorable for surgery, but I had to operate on her because she was severely myelopathic and she couldn't even walk. So unfortunate incident, this one. And yes, I mean, it's beyond your control. And yeah, So she died ultimately of post-op pneumonia. At the time of death, her lower limb power was 2, right upper limb power was same, 3 out of 5, and the left upper limb power was 1. There was a little bit of improvement, but not much improvement, to be honest. Okay. But a good case to discuss further. Right, another one, another case. This is recently done. Again, same thing, OPLL and severely myelopathic with very high GOS scores, and couldn't even walk. You see carefully, the problem is that C34 and C45, 3-4, 2-3, 3-4, 4-5. It's not only the disc osteophyte, it's OPLL as well, right? So I'm seeing, I mean, quite a number of OPLL cases in my area, in my country, and I have done several corpectomies as well, anterior procedures as well for these type of patients. You can see here OPLL plus the disc in this patient as well. See the calcified PLL, calcified LL here. Right, so I had few options. You can see the PLL here. Right, again a little bit of element of dish in this patient as well. Right, so yeah, so either I could have done an ACDF, 2-level ACDF, but it would have not addressed this part behind C4, and also down to this level, half of C5. So what I did, I decided to do a corpectomy, 2-level corpectomy, and I did C4-5 corpectomy. C4-5 corpectomy, total corpectomy in C4, and a bit of a near total corpectomy at C5. So this is the post-op CT, post-op X-ray. Difficult one. This is him. Remarkably improved after the surgery. Remarkably improved. No post-op complications, no CSF leak, nothing. And I have the video of this. I would like to discuss these cases in a different occasion. And the OPLL, it was severely added to the dura, so I had to do the what you call the floating technique for the calcified the calcified segment, calcified area. He was very fine, discharged, no dysphagia, no hoarseness of voice, nothing, no minimal blood loss, GOS score improved, discharged after 10 days. Another case, doctor's father, RTA, deformity, severe myelopathic symptoms, mainly on the right side, as far as, yeah, this is done recently on the right side. So again, this is the MRI. That was a difficult case, really difficult case, severe angulation at that index level. So I did the corpectomy. Unfortunately, I did a very limited corpectomy, partial corpectomy. Mostly the symptoms were on the right side. So I did the majority of the corpectomy was on the right side. And unfortunately, I did not have enough sized, appropriately sized, what you call the plates, an ACP plates, anterior cervical plates for this procedure. So I had to stop at this level and plan it on another day. But what happened was, patient was absolutely remarkably improved, and the patient said, after 3-4 days, I am back to normal. I am back to the position where I was before the incident, and I don't want any more surgeries. But I convinced him, this is for your good. Yeah, I know. I mean, we can stop at this stage as well, but it is not essential to put a ACP plate, but you know, it is for, I explained the indication, but he didn't turn up after that. So he was convinced that he is fine, and he didn't want any more surgeries. So these type of things happen, especially when you don't have whatever the resources in your armamentarium. So remember, I don't have these gauges. I don't have a single what you call lateral mass screw. I don't have a single pedicle screw in my hospital since the day I took over the duties, not even in the previous station. So all these been brought by the patient. So they buy this by the company, and if they pay it, I'll do it. That's it. So so the problem is you need to convince. You need you have to put a big effort to convince the patient that you need the surgery. So okay, I'll come to that later. I will explain that later. I will so finish this case as well. So this is a case of a road traffic accident in a 62-year-old male. This is also 2 weeks back. He presented with this unstable C2 fracture, hangman's fracture, which was really unstable. See the what you call the break here at the C2 body, right? And see, it's really unstable. But he was neurologically intact. He was neurologically intact. So what I did was, I did a C2, C3 fusion, ACDF from the front. And doing a C2, C3 ACDF is not the easiest task, right? Not easy. It's difficult. So this is the approach, submandibular approach we went. And we did the fixation, C2, C3. And this is the patient post-op. Didn't have any nerve palsies, and he did have only mild swallowing difficulty, but we checked the vocal cords and everything. We preserved the recurrent laryngeals and everything, and all these nerves we preserved, and no deficit. So I think he probably needs posterior fixation as well, because we arranged an MRI to check for the disruption of the ligaments and whether to determine whether he needs further posterior procedure. So we are pending the further results, and this is still in the ward. So this was done, I think, 7-8 days back. So I think I showed you during my last webinar on spine case review. I showed you so many spine cases, and this is, I think I did that on 25th of September. This is these cases I did after 25th of September. I just wanted to tell you that that this is where I stopped the previous discussion. All these pedicle screws and everything, I have nothing in my hospital, government hospital. So I have written to so many places, right? So many requests, but it's not been available. So what's the problem here? Patient comes fallen from 30 feet height, say coconut tree, and he doesn't have money to pay for a pedicle screw. He doesn't have money. It's in Sri Lankan rupees, 20,000 per screw, which is approximately $100 US. So how can he afford 8 to 10 screws? So at least 6 screws. So this is the problem. So I have to convince first that you need this operation. We need to fix this spine, right? So I do operate only if it is indicated. In my practice, I never do unnecessary fixations or unnecessary surgeries unless it's really essential. And all these patients had neurology. All these patients recovered. There was no one, which I have shown you up now, did not improve after fixations and decompressions. And when I was in the previous station, I had the same scenario, the same situation. There was nothing. There were ACDF cages, but there were no instruments for ACDF, and so I didn't do ACDF for the first year. And I was a complex spine fellow in King's College and Queen Square, and every day we were doing A-lips, P-lips, C1, C2 fixations, everything. But after coming to Sri Lanka as a consultant, I do at least one single ACDF during my first year. And I did only one fixation because there were no pedicle screws. And most of the patients in that area were Tamil. And I didn't know Tamil very well to convince the patient that you need this surgery. You need this. So you had to bring at least, if you can afford. So bring the, you just buy it. So I'll do it for you. I did not have that ability to convince the patient. So it's the same situation when I came here, when I came to Ratnapura, which is I'm working at present in July 2020. It's the same situation. Nothing was there, right? So, but I knew my mother tongue. So this in this iteration, the most of the patients are Sinhalese. So I could convince them, right? So you need to do this, right? I can't transferring all these patients, to whatever the center. It's not practical. See how many patients we are getting. And sometimes, I had bad experiences when transferring the patients. We lost patients during transfer, and they were not willing to, go to an unknown hospital, unknown region most of the times of the ignorance. How much we convinced them. And yeah, there are so many bad experiences which I don't want to tell you in during this webinar. So I decided, so I had to convince the people. I had to show them that I am capable of doing this. So why not you compromise something and get your work done. So that's what I did. And I think I did a reasonably good job. I showed you during my last webinar, and they were convinced, people were convinced. And now all these people, they are not rich people. Remember, all these rich people, they don't come to the government hospital. Either they go to Colombo, to private sector, or they go to Singapore, or they go to whatever, the foreign, the overseas, UK, and get it done, right? All these patients coming here are very poor patients. So these patients, most of the time, they mortgage, they get loans, and get this done. So I think I'm doing a reasonable job for their compromise. So now see how many cases I have done. This is one. So all these patients, they had to pay for the construct, right? So this is 30th of December. All these patients had neurological deficit, and all these patients went home, and now they are walking, right? So see how many cases. And all these cases were indicated. Not a single case was unindicated. I think you can remember these patients I showed you during my last webinar. So this is two fractures, two contiguous fractures. I had to fix from all the way from the whole lumbar spine. See, he couldn't walk. Now he can walk. Now he's walking. He's coming to you, walking. So I mean, this is the type of situation we are facing every day. So as I said you earlier, if I were to, just if I were to just restrict myself, limit myself to whatever, to a container, and think that I haven't got any resources, so I can't do this. I mean, I wouldn't have done any of these cases. So how many of you would take the risk I told you before with regard to my limitations, and embark on these surgeries and do these tumors and everything, taking the risk, keeping in mind that you don't have a post-op theater to operate if something goes wrong during your daytime surgeries. Suppose your meningioma bleeds and you don't have a theater to open it up at night. I mean, it's not impossible. I mean, you can do it, but I mean, how much effort you have to put it there. So you had to discuss with your anesthetists, and you had to, personally talk with them and get, some help out of the way, and arrange a theater and get it done. So it's not an easy thing. You can, you can do it on and off. You can do it, say, in 2 weeks time. You can do it twice. Once or twice in 3 months time, but you can't do it every day. You can't do it routinely. So it's a difficult thing. So it's being stressful sometimes, difficult, and so many So many issues are there which I don't want to talk about. Sometimes criticism, right? I mean, how much you do, say, suppose you do 1,000 operations successfully, one goes wrong, people will only remember that, and people will criticize you. But I mean, that's life, right? That's how things are wherever you are, in whichever the country you are in. So that is the nature of the human behavior. So this is what all I have got. And I think I have showed you how to tackle with complicated cases with minimal the resources, because it's difficult sometimes for you to change the system. So if you can't change the system, you have to change. You have to change in a way that you don't risk your patient's life. That is the most important thing. So that is the take-home message. If you believe, if you think that you risk your patient's life by trying to do whatever the procedure, then don't do it, right? So you have to have, I mean, so many things behind, and you have to be confident, but not overconfident, as I always say. And yeah, so many things. So I think I had so much experience during my overseas training, because I trained under 40 neurosurgeons, eminent neurosurgeons, 24 neurosurgeons at Queen's Square. All of them were eminent neurosurgeons, and around 16 to 18 at King's College London. And I had seen 40 neurosurgeons operating. For example, I had seen 40 neurosurgeons doing laminectomy, tumors. So, I mean, each and every neurosurgeon has different perspectives, different approach. So there are things that you can learn from them, from each of them. So I grabbed all those. So I think it's a big, you know, a big advantage in my life. So I have seen so many complications. I mean, I've seen the all range of complications from all these local neurosurgeons as well as from the overseas neurosurgeons. So I think that helped me quite a lot to confidently embark on a surgery, rather than, you know, limiting, restricting myself into a nutshell and saying, so I don't have the resources, so I don't have the facilities, and I don't want to operate on this, and I am going to transfer all these patients. But that is not the case. So it's never going to help you. It's never going to help you. So what is the purpose of a neurosurgeon? I mean, if you just want to do your VP shunts, laminectomies, and just simple ACDF, it's not like that. Right? So that is my policy. So, but number one is patient safety. So that is what I have to tell you all. And if you have any questions, you can ask me.
Thank you, Doctor, for your excellent lecture. We invite you to write your question in the chat, and we are going to read it. And remember, after this Zoom, we have the Zoom launch, and the link of the Zoom launch is in the chat.
Okay. If you have any questions, you can ask.
We have some comments.
Yes.
Omar Hamoud say, good presentation, Professor Surratt. Excellent lecture.
Oh, there's Omar. There's Omar now. Hello, Omar.
How are you, Dr. Joel? Or Sora? How are you, Joel Francisco? Good presentation, good ideas from Sora about we must to join of us and to discuss and to make everything not impossible, but to make sure every step by step. Yeah, very good lecture from Professor Sura. Thank you very much for you.
Yeah, thank you. I'm not a professor. I'm just a
student. I know. Okay.
Omar is from Syria. Syria, right, Omar?
From Syria.
Yeah, could you please introduce yourself?
What, Dr. John?
Yeah, please introduce yourself, Omar.
Okay.
Okay, maybe. Okay, I'm sorry. I just didn't
Omar.
understand.
Yeah, are you a neurosurgeon, Omar?
Okay, I am neurosurgeon. Yeah.
Right. You are from Syria, is it?
Yes.
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 Right. Okay. Glad to see you.
Yeah.
Thank you. Thank you.
I'd like to introduce you to Takashi. Takashi, are you there?
Hi,
He's a
Takashi. Hi,
he's a
Takashi. How
Japanese-
are
Good
you?
evening. Good evening. I'm Takashi, come from Tokyo, Japan.
Yeah.
Working at Showa University, Tokyo, Japan. There's a great lecture, Dr. Splash. So minimize, so less resources. So, but you're doing your best. So according to your situation, so I understand the situation. Yeah, well, so you motivate. I'm very motivated to improve my skill. And yes, even in Japan, so it's too many instruments, but so that's according to the situation, according to the institute, and we are doing best for the patients. So I understand a situation when you're doing the best work and great work. I appreciate. Thank you.
Thank you, Takashi.
Okay, Samat, do you have a question or comment? Perhaps not, I don't know. Or Zainab, let's see, there's a couple of people. Oh, Nick, are you there? Can you hear me, Nick, from Greece? Neurosurgeon from Greece. Can you hear me, Nick? No one can hear me today. Okay, any other comments or questions from the panelists?
Here we have some comments
Go
from
ahead.
Thomas Block. Says, thank you. Sometimes we forget what good situation we have in our countries and hospitals. And Hassan says, excellent presentation. Thank you for sharing your experience. Happy New Year for everyone.
Thank you, Francisco, and wish you a happy New Year as well. Happy New Year to everyone.
Very good.
Thank you, John, for giving the opportunity to present on the first day of the 2022. And I wish you will be having a superb and fantastic New Year, coming up with so many great speakers, as you always do.
Great. We're going to have a Zoom lounge now after this presentation, and I'm going to put them. And I hope you can come, Sarath. It could be just for a few minutes.
Yeah, of course.
But I'm going to, let me get the link and put it in there for you. Excuse me just a second. It takes a while. It's a private Zoom where it's not televised. It's not even recorded. Oh man. Okay, I'm sorry. See, I'm having a problem with problems too. Okay, I'm going to put it in the chat. The link.
Doctor, I just write the link of the Zoom Lounge in the chat. So we invite you to everyone.
Oh, you got it. You got it. Thanks, Francisco. That's what co-hosts are for.
You're welcome, Doctor. We invite you to everyone to join us in the Zoom Lounge to talk and introduce yourself, maybe to make links between students, residents, and doctors. So we invite you to everyone.
Yeah, Nick, I hope you come. And Takashi, you have to leave this Zoom before you take that link. Okay, so make sure you copy that link, and let me share on the screen. Let me take my time so that everyone has really good instructions. I find that makes a difference in the attendance in the lounge as soon as people understand. And I'm going to share on the screen also. Just give me a second here to share the screen here with the link. Okay, I'm sharing on the screen, and the Zoom lounge link is right there. Okay, so I'm going to stop this broadcast, and then you can get into the Zoom link. So we'll see everyone there, hopefully. And see you there, Sarath.